Well, good morning, good afternoon, good evening, everybody, and thanks, Dr. Bhatia, and congratulations to all what Dr. Shah has been doing and the team. It's really a great honor and privilege to be with you again today. And you're absolutely right. If anything, this is like a very dynamic field at the moment, and for that reason, as we discussed, I will go over not only like best of ASCO and best of ESMO because there's much more than that. And so I'm going to put a big picture, and especially there will be some basic information, but very critical for our young colleagues. At the same time, of course, I will embed within whatever happened at ASCO and ESMO, but you'll see a whole story. And by all means, I have the chat on. If you have anything urgent, please, by all means, you can chat to everyone or just myself. And of course, there'll be questions and answers at the end. With this said, these are my disclosures. And these are my contacts. And please feel free if you want to copy them, take a picture, whatever you like. And of course, pay close attention to the Twitter. So if anything, we really use the handle specifically to update you all about liver cancer, biliary cancer, and education, nothing else. If you want to look about anything else, whether or what have we, I'm not the right handle, but by all means, anything about liver and biliary cancer or education globally, especially global education, this is the right handle to follow. With this said, I will divide, of course, the lecture into two parts, the HCC and biliary. And in HCC, I'm going to talk about a few components. Some of them might appear basic, but I think it's very important now with the advent of all those therapies that we bring up, talking a little bit about biopsy scoring and staging before we come to the current therapies per se. And I have to really bring up this important component about the biopsy. That's a pretty cirrhotic liver. I would say that I learned that from our radiologist. This is a clear picture about a very cirrhotic liver. And you can tell that what appears to be like a mass on the right side of the liver in segment 2 and 3 appears concerning. Interestingly, it's not HCC. And I only bring it up here to really always bring up that cholangiocarcinoma, among other things, might really mimic like HCC, and tissue is going to remain critical to really diagnose the disease. With that said, I'm sure our colleagues in radiology will argue with me and say, well, LIRADS. So I took the effort and I actually spoke with the radiologist who really wrote the LIRADS imaging system. And if anything, I got the best answer, which is this is a great language for radiologists to talk to radiologists. In other words, same like oncologists do. I have a stage 4 disease. If I call Dr. Bhatia and say I have stage 4 disease, we understand each other. And same thing for the radiologist over here is mainly to understand each other. But it's not diagnostic. As you can see here, actually certain references already are bringing up a limited sensitivity and specificity for the LIRAD to diagnose HCC. So tissue is remaining very critical. And I urge you to really make sure that you look at the tissue. This is nice work that we just reported last year in CCO, looking at the genomic alterations in HCC. And I would say not necessarily that is going to tell us what to do, but if we don't do efforts like this, we will ever know anything. So tissue is important not only for confirming diagnosis, but also to give us some clues about potential therapy. For example, here, in HCC, an FGF alteration might be applicable for certain treatment or clinical trials. And of course, also to better understand the disease so we can move the field forward. So I urge everybody to make sure that you always diagnose by tissue and not by radiologic imaging. With this, I'll come to scoring and staging. This is straightforward. Everybody knows this. We all learned it, and we use it in regard to liver evaluation. Why we use it? You can fault me, because if anything, 20 years ago, we really had a big debate about like what to use as a scoring staging for the different studies. And we could not settle to anything until we came down to the Child-Pugh scoring. Interestingly, it's limited because it does not apply anything to the disease itself, i.e. the cancer. It's all about the liver functionality. And if anything, it consists of 5 parameters. The other limitation is that there are 2 of them at least are subjective, being the ascites and the encephalopathy. And of course, it really can create a certain perspectives that might differ because of that subjectivity. However, more importantly, the reason I'm bringing it up today is because it's very important, especially for our young colleagues. It's not a ice cream flavor. It's not like A, B, or C, and like, oh, just a patient happened to be A or B or C. Definitely, it's not that. And also, it's not a linear function. It's not like A become B become C at the same rate. What I really very importantly stress to understand is this curve. This is really what Child-Pugh is. Child-Pugh is like a long, long, long line from here to Seattle, from Seattle to Nepal, from Nepal back to New York, and still circle around that enough that if you tell a patient Child-Pugh, because of that long line that they're staying on Child-Pugh, they might even forget about it. And then B become a little bit of a curve, and C become a shoot. So it's very important to really recognize that ABC is not a choice. And number two, it's not a linear function, but rather it's an exponential function. And our job is, of course, to catch up patient in A, keep them in A as much as possible, because as we can see, the movement to B and C is really very dire and can be really very hurtful for the patients. So with those two important introductions, I'll move on to locally advanced disease. And this is something that, we kind of like see quite a bit of. This is one of the new versions just published May, 1 month before ASCO in hepatology, looking at what we call the BCLC staging system. I still agree that to the extreme left, it does extremely well. Early disease, good liver, take it out, as simple as that. Early disease, bad liver, transplant, also straightforward. But when we come to intermediate stage and advanced stage, in other words, BCLC B and C, it's really a mixed bag, because there's a lot of kind of variations to this that we have to be very attentive to. In BCLC-C, which is the advanced disease where it applies to what we do mostly as oncologists, one limitation is that, as you can see, Child-Pugh A and B are together, ECOG1 and 2, and 1M1. And we did decipher that in some publication, probably you've seen it, that we published in JCO already. And BCLC-B is having the same challenge at this point in time. And that's a little bit of updated information, was not featured at ASCO or ESMO, but nonetheless is very important to bring up. This is a beautiful work that started about 5 years ago, and then it evolved to this year reporting by Dr. Kudo from Japan. And this is something that we might not be familiar with ourselves. But if you count on top on the x-axis the number of nodules, and on the y-axis the size of the largest nodule, you can probably end up with a certain number, which is called up to 7 criteria. Any of you who are really familiar with transplant might know that number, because up to 7 consists of 2 numbers. One of them is the number of nodules. Let's assume, for example, there's 4 nodules, that's 4. And the largest diameter, let's say it's 4 centimeters, so it's another 4. So 4 plus 4 equal 8. It means that this is beyond the up to 7 criteria. And if anything, patients within the up to 7 criteria, no doubt will fare better when we go to local therapy. We can see very clearly here, when we are in the blue, very limited number of lesions, no more than 3, limited size, no more than 3 centimeters, people do great. And then the green, which is really where the embolization works, up to 6 nodules, no more than 6 centimeters, people also do okay. But then we come up to the green, to the yellow and red or pink, and we see that we come a little bit in more questionable components where we have more than 6 nodules and more than 6 centimeters. Why this is important? Because it appears to be a nice work that was again published by the group a few years later. It appears to be that if you take a patient within the up to 7 criteria, i.e. B1, now this is an important split for BCLCB now in B1 and B2, you'll see that people median time to a taste refractoriness, in other words, where taste does not work anymore, is 25 months, pretty decent. On the other hand, if the patient was B2, in other words, beyond up to 7 criteria, is 16 months. More importantly, on the right, you'll see that time to untreatable progression. And by the way, when I say untreatable, I don't imply only untreatable. In other words, we cannot embolize. Actually, it means that the patient liver is sick, i.e. you can make patients even more ill by doing what's not right. And as you can see here, The time to untreatable progression for B1 within the up to 7 criteria is 101 months, which is quite a bit of time, versus B2, which is only 33 months, which is very limited time. And so we have to really please be very cognizant in regard to those criteria when we come to decision between local therapy and systemic therapy, because no doubt that systemic therapy for B2 might even fare better than it is for the B1, more than the local therapy. So if anything, this is food for thought. How to fix that? I'm not necessarily giving one specific recommendation, but please, a very important component is the multidisciplinary team approach that I'm sure many of you are involved in, or you get involved in whenever needed. But please always be on the table, because if you are not on the table, people will not hear what you can offer. At the same time, they will not necessarily see the different perspective that you can come up with as an oncologist. Now, at this ESMO, there was a interesting, and this was admittedly the only activity that was reported in the oral session on HIKE, which is the hepatic arterial infusion of chemotherapy. And it appears to be that in regard to HIKE versus TACE, people fare better with the HIKE than compared to the TACE. This is an interesting component. I think, however, which is more intriguing than this is to take you back to what I was just talking about, B1 and B2, by the same group, Dr. Shi and group. This data, which is published in JAMA Oncology, quite impressive. They looked at HIKE plus sorafenib versus sorafenib for metastatic disease. This is like a newbie, like we never have seen this, where in other words, you know what, in regard to improved outcome, I need to treat the disease in the liver with the local therapy being HIKE, and same time, I need to treat the systemic disease with the TKI being sorafenib. And as you can see here, survival, PFS, and intrahepatic and progression-free survival are all better for the HIKE plus sorafenib versus the sorafenib alone. That's food for thought. Is anything that really is a new concept, which I would say, considering it is very innovative, rather than bringing the BCLC BCLC-B treatments to C, while doing the other way around. I correct myself. Bringing the BCLC-C treatment to B, which we try to do, for example, with sorafenib plus TACE for locally advanced disease. This is for the first time bringing BCLC-B treatments to C, i.e. local plus systemic for systemic disease. Food for thought. This is very critical, and I think probably this is one of the most important things that we heard from this ESMO. So with this said, I'll move on to a little bit more comforting component of our work today, which is systemic therapy. And of course, we all have heard and we all are talking about the IMbrave150, which is a combination of atezolizumab plus bevacizumab, and it was evaluated versus sorafenib. And this study was very positive, as we can see over here. Median overall survival was not even crossed for the atezo-bev, and for sorafenib it was 13.2 months. Of note, it's really limited only to 3 more patients left. If you look at the x-axis from the New England that really are left on the atezo-bev. So, anticipation is going to be somewhere in the 20 months or so, but it's not going to be forever, understandably. But still, it's a great news and it's a great data. Now, what exactly is going on? This is very important to really understand. Everything at layer 7.7 is anti-PD-1, anti-PD-L1, which we know already does not work by itself. But however, if you point at point number 5, you'll see VEGF. And in other words, it appears to be that anti-VEGF activity will enhance further the activation of the anti-PD-1, anti-PD-L1 at the cell tumor level. And that's really an important component of the atezo-bev that we're talking about. However, despite this very positivity, there's one thing that still we need to swallow a little bit further, which is the issue of the anti-drug antibody. This is data that was reported in the Clinical Cancer Research this February in this year. And it shows over here that all checkpoint inhibitors have a potential for having an anti-drug antibody. What does that mean? It means that you give the drug to somebody and they develop an antibody against the drug. And interestingly, as we can see here, atezolizumab has a 50% chance almost of developing an anti-drug antibody compared to the other extreme pembrolizumab, only about 1 to 2%. And by the way, this data is not only from liver cancer, this is from all tumors. How does this translate to HCC? Actually, if anything, this is from the package insert that was, of course, reviewed and approved by the FDA. It shows very interestingly from this Brave 150 that I showed you that the whole hazard ratio for the whole study was 0.58, which is impressive and really great. For the ADN negative, it's even better, which is also great, 0.39. But interestingly, for those potential about half or less than half of the patients with anti-drug antibody positive, the hazard ratio is 0.93, which in other words, the atezo-bev is as good as sorafenib. Very interesting. And we have to really think about that and try to interpret and put it in contrast. With this said, this is not the only combination. This is from ESMO. It was not repeated on this year's ESMO or ASCO, except for a quick update at ASCO. Nonetheless, it showed for a combination of lenvatinib plus pembrolizumab, a clear improvement in response, including some CRs, something that we never heard of in HCC, quite impressive. And the same thing, mechanistically, what's happening is the lenvatinib as an anti-FGFR, same like any anti-FGFR, it appears when you combine them with PD-1. As you can see here, ardifitinib here is an example. You can see that the Ki67 on the extreme right, you'll see it drops down markedly, which means we're killing the cells, and CD3 goes up, which means we're enhancing the immune activity. So no doubt there is a certain mechanistic activation of the anti-FGFR plus anti-PD-1 that's exemplified by the lenvatinib plus pembrolizumab. Of course, we're waiting for the data on the LEAP-002 study, which is yet to be reported. Nonetheless, so far what we know from that limited data, that the median overall survival is 22 months. Again, quite intriguing. These numbers are becoming really a commonality in HCC, which we never dreamt of. And of course, there is a little bit of a component about how can we enhance that further. This is a very important concept that was discussed at ASCO and ESMO a little bit in direct ways, but I put it this way because it might exemplify it further. This is like a root of a tree. And at the bottom of it, you see VEGF. And you can see that there's a different branches. Where in other words, if you block a certain branch and you want, like, let's say, water or a certain message to pass on, you can cross to another branch. That's what's called degeneracy in regard to the passageways from the cell membrane to the nucleus. FGF is a little bit a higher platform. In other words, it's still degeneracy, but maybe to a lesser extent. And impressively, on top of the root is actually CTLA4 because it's a lymphocyte itself. And interestingly, this is well exemplified in this very important textual graphic. As we all know, CD28 will call CD86 and tell them, guys, would like to work together. He invites them for some very strong coffee and tea, and they become very energetic and pass the message all the way down to the cell membrane level for activation of the immune activity, i.e. kind of, stopping the PD-1 and PD-L1 from doing their job. Interestingly, CTLA4 will come and talk to 8886 and convince them that he's a little bit more cool guy, and he gives them something to drink, which is alcohol, and they fall asleep, all of them, and as such, inhibiting it from happening. This is when the anti-CTLA4 come into play, take CTLA4 away, and allowing CD886 to talk against CD28, allowing this message to pass through. Guys, by the way, you know what I just did? I just described to you in the easiest way. This is like, with my simple mind, this is how I understand it. This is what the Nobel Prize last year that Jim Allison got. That's exactly what it is. So how are we going to translate that into HCC? This is a nice work that we proudly presented it at ESMO World GI. We did not repeat it at ESMO, but nonetheless, this was just in between ASCO and ESMO. Durvalumab plus tremelimumab, anti-PD-L1 plus anti-CTLA4. We can see here that actually improvement in survival is very evident for the combination in the pink color. And interestingly, this required only one dose of the tremelimumab, one dose of anti-CTLA4 is enough to cause that improvement in outcome. And if anything, this really brings us back a little bit for a second to the standards of care until we hear what's going to happen with the Himalaya study that's looking at durvalumab plus tremelimumab. And of course, sorafenib, I don't need to say that. You all know about this. And if anything, Lenvatinib plus versus sorafenib, which was a non-inferiority study, again was positive. We know that as well. And this is improvement of PFS in regard to lenvatinib in favor of the sorafenib. And it brings me back to the component of the checkpoint inhibitors. And please, here is a very important message for everybody. This again was shown one more time at the World GI in ESMO this year. Checkmate 459 that looked at Nivo versus sorafenib is negative. I'm sure all of my colleagues will agree. There's nothing called clinically significant but statistically non-significant. This is called negative. In other words, there was no difference in regard to outcome between anti-PD-1 by itself versus TKI. And this brings us back to the need for the combination therapy, as we just mentioned. And this brings me next to the second-line treatment approach. In second-line treatment, interestingly, at least in the US, and not necessarily to compare, but nivolumab has been approved by the FDA in second-line therapy based on the phase 2 data, simply because of the duration of response, as simple as that. What will be the future of this, especially with the advent of the therapy of combinations that I just mentioned? Time will tell. And by the way, same applied for pembrolizumab, again, because of duration of response was approved. And this is despite that pembrolizumab plus versus placebo was negative. This is from actually ASCO last year, and if anything, published immediately after. And you can see here that, again, one of those clinically significant, statistically non-significant, i.e. negative study. Checkpoint inhibitors by themselves, please, they do not work. We need to combine them with something else. And at the moment, we have the atezolizumab, despite the limitation of the ADA. And number two, we have the durvalumab, and we have the pembrolizumab, and many others, by the way. Regorafenib as second-line therapy is already approved, at least in the FDA, in the US and some other countries. And this is after exposure to sorafenib. Cabozantinib is already approved in second-line therapy as anti-AXL, anti-MET activity versus placebo. And of course, ramucirumab, an anti-angiogenic with a limited survival, 8.5 months, but nonetheless still a positive study. Despite that, really, we still have not the greatest understanding of what this AFP means. But nonetheless, it's not necessarily going to be your jump onto a choice, but at least it is a choice available. And it takes me back to where I was in regard to the checkpoint inhibitor. I really had to set up this to put the stage here because Nivo-Ipi, which is again anti-CTLA-4 plus anti-PD-1, did work. And actually, this was reported at this ASCO. And in addition to that, it was shown also at World GI. And if anything, at ASCO, nonetheless, Dr. Meyer, as a discussant for the session, brought up an interesting perspective, which is totally unscientific, to put an important critique here, but nonetheless is a wake-up call, because if anything, it shows here that Nivo plus Ipi, which include 4 doses of the Ipi, while T300 plus D, which is a Tremi plus Durva, we can see clearly that Nivo-Ipi has shown a clear worsening in regard to adverse events, much more adverse events with the Nivo-Ipi. How it's going to translate ultimately in bigger scale of things, it's time to tell, but please be careful. Ipilimumab or any repetition of the checkpoint inhibitors can definitely have a little bit of a toxicity issue, specifically the anti-CTLA-4. So I will come to the last point, which is option sequencing. And this is exactly what I just spoke about, which is collected, as you notice, from literally just 2 years, literally 2 years. Remember, we started sorafenib, we lingered with sorafenib for 10 years without any movement. And now we have first line atezolizumab, we have sorafenib, we have lenvatinib, we have in second line regorafenib, cabozantinib, ramucirumab, pembrolizumab, nivolumab, ipilimumab plus nivo, and then third line cabozantinib. So we have choices. Choices are good for patients. Choices, of course, bring in questions in regard to how to sequence things. And of course, it will bring in a little bit more component about like how to really pick and choose or how to sequence those things. And until then, I think we probably will see this new perspective, even though it's not confirmatory yet. But if anything, a line minus one approach of the atezobev, lenvatinib, pembro, durvalumab, possibly if all are positive. And first line, we're not going to abandon the sorafenib or lenvatinib. After all, these are great assets that patients might benefit from, and then move it to as such line minus one for the combination therapy, first line and second line and third line. Time will tell. We're not necessarily sure this is what's going to apply, but time will tell. So I'm going to pause here for a second. And of course, I will first refer back to Dr. Bhatia, because I know there's a lot of material regarding to HCC, which I, of course, were required to pass it on. Is it appropriate to still talk about biliary, or shall we wrap it up and take the questions on HCC because of the time limitation?
Yeah, so thank you. This is fascinating. I would love for you to just continue and learn more. But let's say just for you to plan, I guess we have around maybe 10 minutes for you, including the questions. So you can decide if you want to, maybe just summarize the latest and greatest in biliary, and then we can move to questions. And if you have time,
Great. Thanks so much, Dr. Bhatia. This is what I'm going to do. So forgive me, I don't like to do that in any lecture, but this is quite a bit of material. I'll be skipping through some slides in biliary. It's not that long, and I'm going to pause only on the critical component regard to therapy. And with this said, I'm going to specifically tell you two important snippets here. Number one, the genetic alteration in biliary, especially in cholangiocarcinoma or gallbladder cancer, are mutually exclusive. In other words, if a tumor is IDH1, it cannot be FGFR2 or vice versa. Even though there are certain exceptions, but in general, they are mutually exclusive. This is an important concept that we brought up 2 years ago, and it's already published in CCR. The second thing I'm going to skip on is I'm going to talk about the targeted therapy. This is from ESMO last year. If you remember, this was a presidential session, and we were honored to present on the ivosidenib, which is an anti-IDH1 therapy versus placebo. There was an improvement in PFS, and interestingly, there was also an improvement in overall survival, because here the survival, understand, because there was a crossover, if you remember, in the study, did not feature specifically any change. But when we do what we call a rank preserving structural failure time, don't ask me, but this is something that the biostatistician help us with when we can really calculate what if patients did not cross over from placebo to ivosidenib. Interestingly, the survival improved markedly, as we can see over here, with a hazard ratio close to 0.46. So clearly, we're waiting for approval of the drug, but an anti-IDH1 therapy for a mutated IDH1 is definitely positive and available once we have it in the market. The other one I'm going to talk about is the FGFR fusion. This is the great work that we started with. It was a great collaborative work among all of us in regard to the BGJ398. Currently, this is under a phase 3 clinical trial that we are co-leading between Memorial and MD Anderson. But more important, I would like to bring up this important concept, and this again from ESMO. Pemigatinib, which we proudly have shown, has an important response rate for anti-FGFR2, for FGFR2 fusion, of close to 35%. And not only that, but if you look specifically at the genetic fusion versus other alteration versus no alteration, we can see the median survival is 21.1 months for the fusion. And this already, by the way, pemigatinib is already FDA approved and available for FGFR2 fusion patients. I always urge you to make sure you sequence your patients in regard to biliary cancer, because this will imply a lot of things in regard to the therapy. With this said, I'm gonna stop sharing this, and I'm gonna share one more thing, if you can bear with me 1 second, and we'll wrap it up for questions as we promised. And what I would like to show you in regard to that work, we proudly, and some of you know very well about this event, this is the upcoming APPLE meeting, which is the Asia Pacific Liver Meeting, and we proudly, we were honored to actually feature it as a virtual meeting this year, right from New York and from Honolulu, and it's available for everybody. It will be for 2 days, 3 hours, 15 minutes each day. That's it. And the time will be for New York, 6 in the evening on December 4 and 5, and Honolulu, December 4 and 5, it will be 12 noon. So it means, in other words, it will be 3 in the afternoon for Seattle, and at the same time, it will be the next morning, early morning for Nepal. So hopefully we'll see you there. I'll stop here, take any question. Thank you very much.
Great. Thank you, Ghassan. That was great. I love the overview, especially not thinking about this all the time. It puts things into perspective. So we do have a fair number of questions in the chat. So I'll just take those one by one. So Dr. Nabeen Karki asks, can you tell us differences between TACE and HIKE and their primary indications?
That's a great question, Nabil. And if anything, admittedly, we don't know. In other words, we have to remember that HIKE is a very limited approach where infusion of therapy without the emboli, and really still limited experience coming mostly from China and some of it from Japan, but we don't really have the experience. I would hold off on saying which indication one versus the other. I've admittedly more presented the work because, of course, it was part of ESMO and ASCO, and this is what the subject of the matter today. But more importantly, I'm featuring more the view of local therapy being applied for systemic disease. But ultimately, your question will be very valid until we know more information. We'll see how all our colleagues will kind of click into that idea or not. We'll just give it some time.
Great. So the second question is, since confirmatory trials for Nivo and Pembro are negative, do you ever use Nivo or Pembro as single agents?
That's a great question. If anything, still the NCCN in the guidelines approve Nivo in case you cannot give something else. But I would say that the vision will be to give combination and give it in first-line therapy. But understandably, if you are concerned, for example, there's only an example about the ADA in regard to atezolizumab, or for example, the varices are of concern on an EGD that will not permit the use of the bevacizumab, then you give, let's say, a TKI as single agent. By all means, you can use Pembro or Nivo as a second line, no question about it. There'll be always an exception here or there.
Great. And next question is, any suggestions on how to decide between sorafenib and lenvatinib? And can you switch to another if progression occurs on one of them?
So admittedly, a purely scientific answer and academically appropriate will say it's hard to choose. But however, a practical point, and I have to be honest because this is what I do in practice, no question that the lenvatinib is way easier to handle. Hand-foot syndrome is limited. Number two is the hypertension is easily manageable. The improvement in regard, the worsening, potential worsening in regard to weight or appetite can be managed in the appropriate way. It's not really as limiting to the patient. And more importantly, the important thing is that the PFS and the response rate are way better than they are for sorafenib. We have to remember the modified RECIST response rate for lenvatinib is 42%. And the RECIST 1.1 is 26%. These are really rock solid numbers, and we cannot ignore them per se. So no doubt that sorafenib will have probably applicability where it's the only thing available, but no doubt lenvatinib is by far better and better choice.
Great. And Dr. Amar asked, can we use bevacizumab atezo combo in portal vein thrombosis cases?
That's a great question. We have to remember that portal vein thrombosis might have certain implications regard to the Child-Pugh functionality, because when you have a portal vein thrombus, there is a chance patients might have a potential either reduced albumin or ascites, and that their Child-Pugh might even be worsened. If it's really limited or it's only a branch, I would say there's no problem there. But if anything, please, most importantly, make sure patients are scoped before you touch it, because endoscopy will be very critical because varices can occur, especially in a scenario like the one you just brought up, Dr. Amr.
And Dr. Lin, Bruce Lin mentioned he still sees responses of single agent nivolumab in the second line setting for HCC patients.
Of course, I totally agree. I'm not saying no, by all means, but we want to go better than that. And that's really where the combination therapy is coming to play better. But I totally agree with you.
I guess my question to you is, again, as an immunotherapist, how are you going to, let's say, all those frontline combos pan out? Would you pick a winner out of the atezo bevacizumab combination, pembro, lenvatinib versus the CTLA-4 plus PD-1?
Well, admittedly, Dr. Bhatia, we don't know yet. And we have to wait for the LEAP-002. We have to wait for the Cosmic 312. We have to wait for the Himalaya study. There's a lot of kind of work needs to be done still. And it might end up being, you're right, a pick and choose. But at the same time, I tried my best in the kind of, appropriate scientific information that we have to really illustrate what could really lead to a decision making. Number one, I spoke about the ADA. Number two is I spoke about the degeneracy. Number three, I spoke about the kind of mechanism of action. And I saw you very well smiling when I showed the anti-CTLA-4, anti-PD-L1. That's a very solid mechanism of action that we should not undermine. But to be fair, we have to wait for the data to decide how we're going to do that.
I guess one way to look at this will be, durability of responses. Means response rates, obviously, and then durability of responses, and again, talking from the melanoma world, what distinguishes immunotherapy from, let's say, immunotherapy plus targeted therapy combos is not the initial response rate, but it's really the duration of response, the plateau of the curve, which is very meaningful for the subset of patients who are responding. But maybe if you don't inhibit VEGF, maybe you're not going to get to that high number. So I think it will be interesting to see how that pans out.
I like very much what you said. Actually, believe it or not, a great colleague, and definitely we're friends forever, but I'm seeing myself closer and closer these days to Jed Walshock, because this is exactly what we talk about. We are learning from what you guys are doing in melanoma and trying to understand it in regard to HCC. And interestingly, this meeting that's going to come in December, just in 1 month, about the immune microenvironment, actually, believe it or not, the keynote speaker is going to be Jed Walshock.
That's awesome. And I have to admire how you were able to find a time that works for all these different time zones. That's very impressive.
I have to say, sadly, some people are going to hurt on this one. And my deepest apologies for my dear colleagues in Nepal and India. That's going to be a little bit of a tough one. And number two is definitely my sincerest apology also to, and great thanks for our colleagues in Europe, because we have at least 2 speakers coming from Europe, which definitely is going to be at midnight or 2 in the morning. But again, this is the best we can get. But thanks again for the note.
Well, any other burning questions for Dr. Abou-Alfa? I guess not. Ghassan, thank you so much. That was an outstanding talk. We really appreciate you sparing the time this morning. Thank you.
Thanks so much, Dr. Bhatia, and thanks so much, Dr. Shah. And thank you, all of you, and congratulations.